Hi, Emily. Now you can start with your presentation. Thanks a lot from Facultad Salud Pública. We appreciate your time and your knowledge.
All right. Well, thank you so much for inviting me here today. Let me just see if I can, okay. Well, let me see the other screen. But it's a privilege to spend this time with you and discuss the theory and praxis of syndemics. Syndemics is a term that combines the ideas of synergies among multiple factors with a cluster of two or more epidemics. In many ways, syndemics emerged around the same time in the 1990s as other theories of social determinants of health, building upon the Marmot work on social determinants, Nancy Krieger's work of eco-social theory, thinking about a theory of fundamental causes, thinking about theories of social integration with Berkman and Kawauchi and other social epidemiologists. But syndemics came from anthropologists in part to explain the complexity and the depth through which ideas of broader macrosocial factors like climate, like political economy and governance, commercial determinants, all are perpetuating and integrating the clustering, looking at epidemiology and interaction of diseases. So when we think about syndemics, we're thinking about something in relation to epidemics. Syndemics is very useful in part because it's part of this lexicon of epidemic, thinking about the greater than expected frequency of diseases across a population compared to a global spread like a pandemic would suggest, or endemic looking within a well-established area, which COVID is now becoming. But syndemic is really speaking about the clustering of diseases across a population. So it's very much a population facing theory. And I'll explain a little bit later about why thinking about syndemics as pandemics are inherently misguided. So when I think about syndemics, I often think about three overarching rules to identify is something syndemic or not. The first rule is often that two or more diseases cluster in a population. The second is that there's some type of interaction that advances adverse health outcomes, may it be biological, like psychophysiology, or some type of biological convergence. Psychological, really thinking about mental health and the interactions between being distressed because of disease or disease, or the distress actually causing the disease. Or social, which often manifests in stigma. and other factors. But stigma is really the most common ways we've observed two diseases interact in a meaningful and impactful way. And then, of course, there's this third aspect that aligns with many other theories of convergence, or theories of fundamental causes, or eco-social theories of social determinants, really, which is that there are these combined upstream factors that are cultivating and perpetuating the possibility of diseases to emerge and interact and cause a very different type of sickness that is often measured. For example, in the global burden of disease, often what's measured is distinct diseases, but I've never interviewed anyone, and I've interviewed hundreds of people and spent hours with different people around the world. I've never met anyone who had only one problem. And Syndemics really complicates the idea that we need to think about and understand disease as a singular experience or factor. And that's true among individuals as well as it's true among populations. I led a series of papers in The Lancet in 2017, and our first paper in that series was led by the architect of syndemic theory, Merle Singer. And this is a model that we put forth in that paper, which I think is a really helpful way of thinking about it, because what makes syndemics unique from other social theories of disease is thinking about the fact that it is these larger factors that are hard to measure and articulate in very discrete ways. But the fact that these conditions come together, although I have a new special issue in Social Science and Medicine coming out that is all about deconstructing and understanding this complexity that is driving the interaction and clustering of diseases. But you can see from this model here that the most important point is that these diseases do cluster in a meaningful way in a region, in a city, in a space, in some geographical frame, interact, and then enhance disease transmission, progression, and negative health outcomes. So the idea is, without these mutually perpetual forces and the interaction of these diseases, people become sicker because of these interactions. But without them, they would not be quite as sick. And I'll talk about what that means in a minute in relation to how we think about and measure and convey what is making people sick. So one of the first papers that Merle Singer started writing about syndemics was about HIV/AIDS. And like much of the work on social determinants of health and the work that really complicated how we think about infectious disease, Merle Singer was working at the Hispanic Health Council in the 1990s, really working in a service and policy perspective. And what he realized is he couldn't understand and advocate for care for people living with HIV without looking at the more profound and distinct social and structural experiences and behavioral experiences framing the epidemic in inner city Hartford, Connecticut, in the northeastern United States. And this played a powerful role in how he conveyed and talked about AIDS. Like so much of this work on social and political determinants, thinking about AIDS was really, in this case, in this community where he worked at that moment, was looking at substance abuse and violence as intertwined with the experience, diagnosis, and care for AIDS. And you can see the way that he conveyed, the first, for some reason it's not on here, but usually I do include on the slide a triangle, how he first initially framed SAVA, substance abuse, violence, and AIDS, to look at these three corners as part of a whole. And what that does is it illustrates that, and you can see here in the middle of the Venn diagram, that is the inherent syndemic. So the overlap of these three conditions and experiences produce profoundly different experiences than when you would have one experience alone. So I wrote the first full-length book on any syndemic. And in part, I started doing this because I was working on, before graduate school, I was working at the large public hospital in Chicago called Cook County Hospital with Mexican immigrants, largely undocumented, living with diabetes. And I was tasked with doing a small ethnographic study that's to inform this larger study I was working on as a research assistant. I was tasked with going around the city and asking people about their diabetes. And what I found is that no one wanted to talk about diabetes. They wanted to talk about trauma, immigration, psychological distress, violence in their home, in their lives, in their memory. And and also structural risk. So all of these factors, and also a profound social isolation because of their undocumentation. And through this, I cultivated a study that would provide an opportunity to fully understand the inherent and complex experiences through which people spoke about diabetes. So I interviewed 121 women, and I spent between 4 and 6 hours with each woman, just basically listening to their story. 2/3 were born in Mexico, 1/3 were undocumented, 1/2 were only Spanish speakers, although most people preferred Spanish. And what I found is that if we want to understand what people live with and what epidemics exist from across contexts or within a specific context, the only way to really understand what's going on is to think about it syndemically. So it started pushing me to think syndemically when I was, listening and learning and trying to tell the story that these women shared with me. So I created this idea called the vida syndemic. So of course, la vida is life. So violence, abuse, diabetes, depression, or violence, immigration and isolation, depression, diabetes, and abuse became this theory of what women were conveying as cultivating sickness. So there are real biomedical and public health ways of thinking about this model that I just shared. There are meaningful ways we can talk about, convey, understand the links between depression, diabetes, poverty, trauma in biomedical speak, right? How we think about these terms within the clinic. And I think it's important to convey these ideas and these overlaps within a clinical or public health space because that's where a lot of the meaningful interventions are parlayed. So in this way, when you think about the complexities driving the vida syndemic, I think about poverty as affecting what people eat and the stress they carry. We think about the links between stress and body weight as fundamental to diabetes, about how poverty and stress escalate depression in meaningful ways, about how depression is linked to diabetes biologically through biobehavioral pathways. For example, cortisol in the body makes you eat more, makes you stress eat, but it also affects the body psychophysiologically. Depression itself and cortisol in the body actually acts on the cells to become insulin resistant. So there are real biological, psychological, emotional, behavioral pathways in which depression drives diabetes. And of course, especially during the first month to year of diagnosis, diabetes can cause a deep level of depression and anxiety. Partly I was working on and understanding this idea of looking in depth at people's experiences as explaining these overlaps and epidemiological data on comorbidity of depression and diabetes. So it was easy to, in some ways, explain all of these unexplainable, opaque comorbidities that people were talking about. And there were a lot of ideas that, this could be caused by this or this, but really diving deep into the intimacies that were underneath women's stories. For example, one of the most profoundly impactful causes of depression among the women I interviewed, and extreme distress, including rumination and memory of trauma, was feeling socially isolated from sisters and mothers, feeling detached and sort of trapped in Chicago when they could not, because of their undocumented status. And many of the women I interviewed were older, over 40 years of age, and up to about 75. And how many were in Chicago to care for their grandchildren, but could not leave, in part because of their undocumentation. They didn't want to leave their children stranded when they provided a lot of childcare. I then wanted to understand what it meant to live with diabetes and face extraordinary poverty amidst the emergence of a new non-communicable disease in settings. And I don't mean new by being really new biologically, because we know that hypertension and diabetes and other cardiometabolic problems have been long in context in low and middle income countries, for example, in India and Kenya and South Africa, where I've worked. And, largely, I was invited first to Delhi, in part because there had been some documentation of my research among my research team that there was increasing rates of diabetes among the lowest income people in Delhi. And so they invited me to come on to try to understand what was that experience like and how people thought about diabetes and how that differed across income groups. And I found that it differed quite a bit in meaningful ways, as you would expect with income. But I also found that people thought about and experienced diabetes in fundamental ways that also affected how they cared for themselves. So in Delhi, often something you'd heard, well, there's a lot of victim blaming about why people got diabetes in the United States. I found that in Delhi, everyone or many people would say, well, everyone has a little diabetes. It's not a big deal. The social phenomenon of diabetes was more accepted and normalized, and less focused on talking about what the individual with the condition did wrong. Now, the kind of frames in Soweto and Nairobi were somewhat similar, or somewhat more similar to Chicago. But what I found, which was really important, was in actually both Nairobi and Soweto, and there's been some other studies in Lesotho and Swaziland, and I think Zimbabwe that have suggested similar things, that there was a profound link between, and this is socially, when I talked about stigma as a link between two conditions, we found that people would often not want to share that they had diabetes because for over 2 decades, clinicians, faith healers, leaders, community members had been trying to destigmatize HIV to promote treatment and care. But as a result, they had often a mantra was, HIV is just like diabetes. It's just like cancer. And actually found out the stigma played out in a similar way with breast cancer patients. But what we found is that people often wouldn't want to disclose their diabetes status because people thought that they were conflating an HIV or hiding an HIV status. So that's a good example of how stigma can affect how people talk about and express their experience with one condition because of the stigma associated with another. And a really important other finding in Nairobi, which was that, the country I was working in that had the most dependence on international aid, including PEPFAR. And what we found was that many times people would be very open and committed to their HIV medication that was paid for by PEPFAR, and this was at Bagathi District Hospital in Nairobi. And we found that most people would actually strategically take their insulin for diabetes, in part because they had to pay for it out of pocket, and they also had to pay for the diagnostic test out of pocket. So that complexity of why people do care, take medication or follow treatment regimens because of cost and burden on the patient was really powerful and a pretty common finding in anthropological scholarship. But that actually, the cost of care really made an impact on what diseases people treated and why. Often people would say, I can't pay for my diabetes medication because I have to pay for my kids to go to school or to put food on the table, which are obviously normal demands. And for a long time, well, actually very quickly into the pandemic, when we started seeing the emergence of comorbidities that were driving adverse health outcomes due to COVID-19, people were wondering if COVID was syndemic. Richard Horton wrote pretty early on, I guess maybe last summer, 2020 summer, he wrote in the Lancet, is COVID, it's not pandemic, it's inherently syndemic. So is it syndemic? It inherently is, right? And this was coming off the tails of Richard Horton calling COVID-19 pandemic in other terms, in other ways, and using this idea, and they actually had a Lancet commission called the global syndemic, which I responded to pretty strongly because I think the idea of a global syndemic is really misplaced and it is confusing because a syndemic is inherently local. And by calling a syndemic global, it erases the profoundly influential histories and complex local contexts and drivers of why and where diseases cluster and interact. I think a really good example of COVID-19 is inherently syndemic in the United States. Clarence Gravely made this great argument. This really important and astute argument, although I do add this little thing on top because I think political leadership was a bit discarded in this framework. But thinking about how the U.S. rejected years of pandemic preparedness and how COVID-19 fell along because we had nearly zero prevention in place, especially from the earliest year, from the 2020 pandemic year. How COVID ran along terms of our fault lines of inequality. It really affected people with people of color, low income families, especially Black Americans, have the highest rates of diabetes, of hypertension, of other conditions, respiratory infections, particularly in Appalachia, among Native people in the U.S. Where our cardiometabolic diseases cluster is where COVID-19 interacted and also parlayed into profound loss. A lot of this was also linked with what jobs people have and what kind of security people have and social control people have to be able to choose. Can they stay home? Can they afford it? Is it safe? Is their job amenable to that? Of course, this was something we've seen across Latin America as well. But in this case, the political leadership was central to making COVID syndemic. This was contrasted, of course, to the most extreme example of New Zealand, which shut everything down, in part because of its geography, of course, and it was a small island of 5 million people. But they were able to shut it down and prevent COVID from really moving at all. Of course, that's changed a bit as they've opened up and released some of their policies due to vaccination. Again, Germany was, at least in the first year before the kind of vaccine debacle, they did a really good job of shutting things down and testing, containing, communicating, and preventing COVID. And this was also similar to the work in Rwanda, where in these three latter cases, and partly they're contrasted because they're led by women who are indicating and communicated through compassionate leadership and an idea that, people will follow and listen. And there was a lot of racist commentary, especially by Americans early on in the pandemic, that said, specifically, other people, like specifically African countries, need U.S. leadership right now. And I thought so frequently, and maybe many of you did as well, that it was just such a poor kind of perspective on how everything was really working out. And I thought, and I wrote about in Think Global Health that, the United States really needs to clean up your own act. We don't have no right to critique others, especially in that moment when we were failing so terribly in responding to COVID. And then I wrote a bit later, actually, this is with Lance Gravely. We wrote about how, COVID inequality in politics cultivated this vicious syndemic. And I argued that, the lessons of this work is really that a more equal society is a healthier one. And of course, this is pretty much the bread and butter of social determinants theory. And all of these scholars have been working towards this work to make a more equitable world, but to also really recognize how fundamental political determinants are. But what the syndemic theory framework allows you to do is to not only identify that works, but show the inner working socially, experientially, biologically, and clinically, and how that functions and how that plays out. I actually just wrote a book about some of the social and cultural factors that play out in white communities in rural America. I grew up in a small town in Iowa, and which is central in the Midwest, west of Chicago, about 8 hours. And my brother-in-law led the COVID response. And I talk a little bit about when there's no policy in place and when personal responsibility, which is what the Trump administration called for again and again, what happens when personal responsibility fails, which is inherent when, as the story of the United States and many countries, especially in the age of extreme neoliberalism, what happens is that the power of money displaces the needs of the people. And this is really what happened. So people, there was extraordinary performance of power and support for Trump in a very, very conservative area. And I talk a lot about what drove people to reject masks and ignore the pandemic and really act like the pandemic wasn't happening and really attack people who acted like it was a reality. And it's a real rejection of science, which has been, common across the globe, especially in America and rural American societies, which is powerfully politically motivated. And this also, I don't talk a lot about it in the book, but I have a chapter by Rebecca Katz, who is a leader in global health security and a good friend of mine at Georgetown at university, where I'm a professor. And, she spoke about, how they had prepared and they'd planned, especially with the Obama administration, to respond to a pandemic threat like COVID, and they'd written a playbook to respond. And one of the complexities of the lack of response is showing how poorly scientists are at communicating knowledge and legitimating their voices. So I think that's a really important lesson learned from COVID. And, I know that as we think about syndemics and as we think about global threats and even the next threat, coronavirus threat, I have my friends who are Arctic scholars or scholars of astrobiology suggest that we have to really think about climate and viral threats, in part because of the melting of the Arctic. There are going to be new viruses that emerge, and we have to be ready for thinking about, responding, and understanding what that means. But when we think about climate change, we think about, of course, temperature, other weather extremes that displace people, rising sea levels, how all of this cultivate these other aspects that we measure and talk about, and how there are so many outcomes that are overlapping and entwined. And I think when we think about climate and health, there's just no way to think syndemically, because climate is going to be driving the most emergent and overlapping conditions. And when we think a little bit about climate, as I do so much, I think about diabetes, it's hard to disentangle the influence of corporations and carbon impact of companies that have been producing and investing in big food, making sugar, more sugary foods and sugar sweetened beverages, alcohol, tobacco, all of these products that are making us sicker, and how we've learned from COVID-19 that the extraction of carbon and exploitation and production that has created risks for climate change through carbon emissions also has produced risk in such deep and intimate ways into our own biological realities and our biological risk. So this is structural, but maybe we could call it eco-structural, because it's deeper and broader and more entangled in meaningful ways. And so when I think we can think about syndemic problems, we have to really recognize these mutually impactful and interactive determinants. I don't even like the word determinants, because it obfuscates really what's at the heart of the matter, what's driving and cultivating this real, the real complicated and messy background and history to explain why people suffer unequally today. I think it's useful also to think about the Rockefeller Foundation's Commission on Planetary Health. Some things that I actually took from that commission, which was brilliant and important, and probably many of you have read it, is to really think about using an imagination to think beyond boundaries. And I think this is one really important reason why syndemic thinking matters, is to use conceptual and empathy. Conceptual and empathy failures convey over-reliance on GDP as a measure of human progress while overlooking environmental harms. And I think Greta Thunberg and many of my anthropology colleagues argue that we have to stop looking at these, profits and political and economic gain as the primary focus on how we will advance as a human species, because the ecological harms of doing so are too high a cost. Also, of course, transdisciplinary thinking, we have to know and think between and around and through each other's niches in which we are siloed. We have to work together. And also we can't sit outside of governance. We have to engage and deeply try to transform the ecological and human impacts of these crises that will continue to intensify. So syndemics matter because it inherently changes how we think about disease. It puts climate, it puts people, it puts ecologies and animals even at the center. It recognizes that we never experience one disease in isolation. That's a false reality. And we also have to think about what drives poor health. It's not one thing. And that conditions cluster and overlap with all of these factors that make people sicker. And that responding to syndemics have to be upstream and have to be multi-pronged. So when I think about a transdisciplinary agenda, I think about changing how people think about diseases, about bringing together multiple fields, which I think is one of the objectives of your faculty. Thinking about anthropology and sociology and history and biology and nursing and public health and epidemiology and medicine and biostatistics, and only together, by thinking together in a room, at the community level, at the local level, at the nation state level, and at the international level, will we be able to put forth effective solutions. And as we are working together to put forth solutions, we need people in power who will effectively integrate and promote them. So, really thinking about a comprehensive view of how syndemics emerge, converge, interact, and change through time will be important as we look from the future. And one thing that I argue for and have a piece coming out in Nature Human Behavior in January is about how to move from ethnography to epidemiology to really understand the complexities that are driving syndemic problems. So we have a paper where we did a couple ethnographic studies in Soweto. I work in Soweto, which is a township of Johannesburg, South Africa. I've worked there for about 10 years. But what we did is we drew on our ethnographic work to build a local scale. So a 21 point scale of stress, and then a 16-point scale of wellness and coping, what people do to be well and to live well. And we use that to explain multimorbidity. And what we found to see how it interacts with multimorbidity, and actually in our evaluation of what we put at the center to measure the syndemic itself was not the disease. And I think this is important when we think about syndemics and when we measure them and when we create a way to think and understand them, we have to put, we really have to put some measure of a good life at the center. Or I mean, you could look at morbidity, mortality in general terms, but I really think quality of life. So one measure, which what we used for this theory, was to look at the influence of stress and multimorbidity on quality of life. And so by using these locally driven scales, we actually found that different types and levels of stress were much more impactful than multimorbidity on quality of life. And by really looking at the local level at what cultivates sickness, we're able to see how profoundly non-medical problems are perpetuating medical problems. And also, we need to have better methods to identify and understand and test syndemic interactions. In part, this is because of the global health funding context in which we live. So this obviously should change, but in so often where we get money, for example, the Gates Foundation, is closely embedded and entwined with technical fixes. So how do we fundamentally also tackle upstream factors? So also taking this seriously, these roles of upstream factors from, who's emitting carbons and who's creating and has the power to determine what's on our plates and what we consume. So upstream solutions are obviously climate policy, food policy, housing policy, healthcare policy, how much people make all around the world where I've spoken to people. One of the profound, especially families who are struggling or who are identified as low income, the biggest stress in people's lives is money. Also immigration policy. And then, when we think about interventions for syndemics, we of course have these fundamental upstream solutions, but we also have to think about these fundamental clinical interventions. So at least, really reframing how care is delivered and what it means. So person-centered medical homes, seeing people as people. Also incentivizing how healthcare providers are incentivized. I had one baby in the UK and one baby in the US. And it was interesting in the UK when I would talk to my primary care provider and ask what happened if someone got well or stayed well and they had a chronic disease like diabetes. And the care provider was like, well, of course I get paid more if they're healthy, not by doing more tests, not by prescribing more medication, but if they're able to help patients live healthily and manage their chronic illness, that's how they're incentivized. So what that looks like is a cultural and a decision, right? And a political decision. And those factors really matter and play out in meaningful ways. And also really thinking about who's in the clinic and who's available to provide care for people struggling. especially with multiple conditions. So, you know, it's not just physicians or mid-level health providers really matter, but so do social workers, lawyers, psychologists, managers. And then, you know, something that we found again and again in the United States is how important house visits are. Finally, or second to last, is this idea of community-based interventions. And this is probably something that you all know very well as well. But, you know, really providing opportunities for people to collectively come together with people who they are close to and learn from and identify with, to talk about and deconstruct the factors that they're struggling with and how they understand their identity transformation with the diagnosis of an illness. And then downstream solutions, you know, really thinking about how to invest in people and cultivate good health through non-medical interventions matter. So that is, I don't know if I'm at time, but that is my talk for today. And I'm happy to take questions.
Muchas gracias, Emily. Muchas gracias por la ponencia. Tenemos tiempo para preguntas y respuestas. El profesor Juan Eduardo Guerrero está preparando las preguntas y él me las va a pasar y yo te las traduzco. Emily, thank you very much. We're gonna be having some Q&A. Professor Juan Eduardo Guerrero has been collecting the questions and he will present them and I'll translate them for you if you need to. And then there is a translation.
Okay, thank you.
Juan Eduardo.
Did we lose him?
I don't know. I'm trying to see if in the other room I find the chat with the questions.
Ahí es posible que esté escuchando.
Sí, señor, ya te estamos escuchando. Activa la cámara.
Ah, bueno, muchísimas gracias. Muchísimas gracias. Bueno, estaba en otro enlace. Emily, muchísimas gracias. Maravillosa tu conferencia. Tengo algunas preguntas para poder abrir este diálogo tan interesante. Pienso que este tema de sindemias nos permite unir la salud pública. En tiempos pasados, digamos, ha existido una política de separación de funciones a nivel internacional. Y en esa separación de funciones se nos ha dicho que los determinantes deben manejarse aparte y que las enfermedades se manejan aparte. Y me parece que allí hay una pérdida del campo de dominio de la salud para poder intervenir integralmente en las poblaciones. Y me gustaría muchísimo conocer tu concepto alrededor de eso, porque el término sindemia, personalmente pienso, nos va a permitir unir, integrar y generar equipos multidisciplinarios para dar soluciones desde el campo de la salud, actuando en la sociedad. Si nosotros vamos a comunidades muy pobres, como las que yo viví, por ejemplo, en Centroamérica, en ese tiempo no hablábamos de sindemia, pero decíamos desnutrición, diarrea y dengue en los niños tienen efectos y causas comunes. Y no puede haber unos trabajando en dengue, otro un programa de diarreas y otro trabajando en desnutrición, 3 programas diferentes sin unirse. Entonces me gustaría muchísimo, Emily, que tú puedas reforzar ese concepto para la salud pública, porque me parece que si lo logramos entender, podemos unir lo que nos están separando hace unos años con lo que se llama, digamos, la separación de funciones. Y esa sería la pregunta que quisiera hacerle.
Yeah. I want to respond in English because
Okay.
my Spanish isn't as good. I would say that these are deep and broad questions. And I think these are also questions we've grappled with or, dealt with for the last 100 years almost in international development and global health. We know what to do. We don't do it. These are questions that we had in the 1930s when, global leaders were grappling with the fact and doing experiments all over the world about what is better, investing in social and economic development or investing in quick technical fixes to fix problems. And again and again and again, money and power has won out over what we know is important and impactful. So the reason why there are independent, dissociated interventions for all of these problems are because of global agendas and power and who funds what is provided. So a lot of that is because so much money is driven by the Bill and Melinda Gates Foundation. A lot of it is because international donors don't always invest in and promote states to invest in their people at a state level. So much has been, and this is partly because of the exportation of biomedicine and remaking of biomedicine across different contexts. But if we invest in people by elevating how much, and maybe even state grants, especially if you put money in the hands of poor people, we know that there are transformations and elevation of health and reduction of disease. We know that. There have been lots of studies that demonstrate that, but there has to be political leadership that invests in people to reduce poverty, elevate people's wellness and ability to live in a safe and clean and environment in which they can live well. And of course, a lot of this has to do with global agendas and the power from which and how money is distributed and determined and flagged. But a lot of it is also determined in the clinic itself. So I've never worked in Colombia, so I can't say that I know what it's like in the clinic, but I have worked in a lot of different places. And I have spent some time in South America traveling and learning. I just spent about a month in Chile, and then in the early 2000s working in Mapuche clinic it was a state clinic, but where mostly Mapuche were seeking care. And at the time there was an incredible cultural broker who worked, and she was a machi, a traditional healer, and she also was a midwife. And she was working between and within that community to elevate care. She was a really good example of how to provide more comprehensive health care and how people can be cared for and seen as people. But so often people are seen as diseases, or people are looked at as outcomes, or people are looked at as visits, right? How many visits have been seen? How many people have been seen? Did you get through 60 people today? How much time did you have to see people? And that's a problem. And part of this is because the ways in which we see people are through their diseases and not as people. And that's why one of the interventions, in addition to the policy level interventions and the ideas of recognizing how the structure of global governance and global financing is inherently undermining people's health at individual levels. And we saw this by PEPFAR and other global aids determinations of who gets money where and why in Nairobi. Inherently, I saw it in multiple interviews of people demonstrating how they would tell me, I have to, because someone in Geneva or New York or Seattle decided that this money would be for an AIDS clinic, and only people who got money, who got care and comprehensive care had to have we call this therapeutic citizenship or biological citizenship in anthropology, which people outside of anthropology don't always understand, but it's a simple thing to understand, that global international or global agendas affect how local people receive care in meaningful and impactful ways. The people we talked about, and I mentioned this earlier, but the people we talked to who had HIV and diabetes said, I follow my diabetes care so religiously. I always take my medication. I can't afford the diabetes medication. I don't take it. And then people with diabetes would say, very frustrating, because those with TB medication don't have to pay for it. Those who have malaria don't have to pay for it. Those who are on antiretrovirals don't have to pay for it. Why do I have to pay for mine? I can't afford it. We know that those decisions where there's a lot of political capital in HIV fundamentally shape individual people's lives and inability to live well. Okay.
Thank you. Gracias, Emily. Muy bien. Una pregunta relacionada con la de Juan Eduardo. En este modelo más integrado de pensar las causas y las necesidades de atención, ¿hay fallas en el entrenamiento médico y en la forma de pensar la medicina especializada? Porque termina entonces un poco en lo que decía José Eduardo, lo que tú estás diciendo, ¿no? No solo es el programa, pero ¿cuál es el especialista que tiene que ver una persona o comunidades donde hay procesos sindémicos en donde la necesidad de especialización es una especialización hacia la sindemia, pero no necesariamente hacia el manejo clínico? ¿Ves algunas fallas en la forma como se está entrenando el cuerpo médico y alguna posibilidad de que se cambie a modelos más integrales y biosociales de cuidado?
I think I understand what you're asking me. And I think the answer is probably something you could explain very, very well, is that part of it is the organization or reorganization of care. I mean, the whole movement of global health, of global mental health specifically, is thinking about who provides care and what kind of care we need, because medicine is fundamentally integrated and organized by gatekeepers, and partly, at least in the American Medical Association, and I've studied the British Medical Association and the Kenyan Medical Association and the South African Medical Association and the Indian Medical Association. And although there are differences between them, at the heart, their role is to protect doctors, not people. And by doing that, they have enabled really illustrious, well-paid careers where training is expensive and paychecks are reliably high. But what we need is not, and I don't want to say this because in a lot of contexts, there are not enough physicians, right? But what we really need are people who can provide crucial on-the-ground care. So community health workers are really crucial, but mid-level health workers are the most important. We need people who can educate, who can care for. I mean, there's lots of good models for this, but really changing the structure in which care is provided. So a lot of things, I always argue in the United States, is that we need to have a primary healthcare center in every community center, right? It shouldn't be in the hospital. Why is it so hard for me to get my doctor to see my kids to see my pediatrician? And I have a PhD. It is so hard for me sometimes to get them into the physician. So I go to urgent care because it's in my neighborhood. But that's not my long-term physician. But that is something we see again and again is gatekeeping, and the costs remain high. And a lot of this is also linked to the financial arrangements of the health system. So if we don't have a single payer health system, so we have two major things. We have how much money is organized and negotiated to keep costs low. And we also have how care is provided, right? These two risk pools and care and places of care, right? So you can have private and public places in which you get care. But if the price of care isn't negotiated among the millions of people in a nation, they're negotiated by private health insurance companies, for example, in the United States. And this is, I'm talking about the US specifically, but this is very different than the NHS in London or in England or other contexts, but most places where I have worked are more balanced, both private and public. But the private health insurance keeps costs inherently high, and user fees impede people's access. We know that. There's so much research that shows user fees, even getting to the clinic. So many people I've talked to around the world just say getting to the clinic is really hard, and that I don't go because I lose a day of work and I have to pay for bus fare. That's really a problem. Right? People need to be met where they are. I mean, I actually think that home-based visits are really crucial, especially for the elderly, especially them. But I don't know if that answered your question.
Interesante. Yo pienso que, César y Emily, que la pandemia nos ha dado una oportunidad, posicionar el tema de sindemia. Pienso que antes de la pandemia no estábamos tan seguros de las sindemias. Y pienso que la pandemia le dio un salto cualitativo al término de sindemia. Y me parece que hay que aprovechar la oportunidad de trabajar a dos niveles. Y ahí te pregunto, Emily, un nivel es a nivel de los gobiernos, de la gobernanza global y gobernanza en los países. Pero el otro nivel es que la población nos comprenda qué significa trabajar como sindemia. Porque la población está muy ligada al otro modelo de la enfermedad única y no entiende que hay condiciones, o si lo entiende, no lo integra. Y es necesario que la población también comprenda qué significa el término sindémico, porque en esa forma se empoderaría más y llevaría en alguna forma a que los profesionales de la salud tendrían que producirse cambios muy fuertes en su formación, porque la formación de los profesionales está aislada del manejo de la sindemia en forma integrada. Entonces, pienso, y me parece que sería interesante, Emily, con tu experiencia, nos digas cómo esos caminos, porque son varios abordajes que tendríamos que dar para posicionar el tema de sindemia en diferentes espacios en los próximos años.
Yeah, that's a good question. I think that it's important to think about how government has its own culture, about how biomedicine has its own culture, and about how communities have their own cultures, even within the same country. There's multiple cultural things that ways people think and talk. And I think that culture can change, but I think it's slow. So I think, first we have to change the culture of money, right? Global governance, national governance, how people think about investing in health. And that's been a really long, challenging road, which I've already talked about. I think changing the culture of medicine is a structural. First of all, people have to buy into it, right? The people who determine, and this is governance as well, but how care is structured and situated, that has to change. And that, can change with some really powerful or eager or equity-focused leaders, a new minister of health that is completely devoted to caring for people. I think the reorganization of clinics that also incorporate legal and social protection and rethinking what the clinic means is a shift in culture. But I think it can be done. And I think it can be done rapidly with the right leadership. Now, I think that when we talk about culture change among populations, I've just been thinking a lot about this because I wrote a piece on vaccine hesitancy. And I've been, this is just for Scientific American, and, just thinking about the US vaccine hesitancy among white folks, especially, who are really resistant. But, a lot of reasons people think about conspiracy theories or talk about certain things are because of social power. People are trying to just survive. And especially when you feel powerless in one area, you might seek power in another. For example, through saying vaccines don't work, or I don't trust this, this or that. And partly that's because people don't, at least in this context, for vaccines, I argue, and I've been talking about, there's an anthropologist, Jay Sobo, who writes really powerfully about this, and she's influenced a lot of my thinking. But we were emailing, and she said, you know, a lot of people actually want to be told they have to take the vaccine because there's so much social pressure not to. So and your sickness, what makes you sick is structural and social and emotional. And it's not just about what you're diagnosed with. It's a very individual experience. But, you know, providing care for people has to be a systemic change because, you know, there are amazing clinicians, physicians, nurses, community health workers who do see and try their hardest to care for people as people. But if the system doesn't change, they inherently cannot do that or succeed in doing it in the level they would like to do it. So, you know, there's a lot of evidence showing all of this. I'm just trying to bring it together.
Muy bien, Emily. Muchísimas gracias. Muchas gracias. Realmente estamos, creo que en el tiempo exacto para terminar. Ha sido maravilloso esta conferencia inaugural y el mensaje que nos dejas a todos, yo pienso que trasciende todo el Congreso. Entendemos que este tema de sindemia se posiciona en ese momento de la protección de la vida y de la salud como un bien común. Y posiblemente tenemos que hacer muchísimas transformaciones y tú haces parte de esa generación que con toda seguridad va a contribuir a que ese cambio se dé. De modo que mil gracias, Emily, por haber estado con nosotros. Nuestro cariño especial y que sigas iluminando esta salud pública que tanto necesitamos a nivel global. Muchísimas gracias, Emily. Muchas gracias.
Gracias. Sí, chao.
Gracias, César. Gracias por estar con nosotros.
Gracias, Emily.
Mucho gusto.